Are you one of the millions with a health condition that requires you to use needles? If so, please listen. Disposing of your needles properly is a big responsibility. Accidental needle sticks in the home can injure family members, children, and even your pets. I am Dr. Drew Pinsky, and I have an easy solution for the safe disposal of needles and the end to accidental needle stick injuries. You may have heard about Sand Mini. The Sand Mini is the affordable, foolproof way to dispose of needles. It's FDA approved, and with Sand Mini, it is easy. Just insert the needle, press the button, and in seconds, the needle is incinerated. Now you have a needle that is completely safe to discard. No sharp points, no bacteria, germs, or pathogens. Make sure your home and business is sand safe. Every needle, every time. Go online right now and use our special promo code DREW2020 for our best offer ever on the Sand Mini. That's nomoresharps.com, and remember, use my promo code DREW2020 for our special offer.
There you go.
All
Sorry,
right.
I beg your pardon, start over.
So you can start. You can intro it.
Hey everyone, it's a dose of Dr. Drew.
All right. So I was just saying that we were going to have a special guest in here in just a second, Dr. Scott Jensen. I saw his thread yesterday, his video, and I thought, oh my God, I must interview him. There's a lot to get into here. And I also was thinking about Alex Ashkashvili's comment yesterday when he went, what the hell, in terms of what's going on at the University of Washington, the COVID-19.healthdata.org site, where the graphs are sort of seemingly lost. And I thought, I was thinking a lot about that this morning, and I think things are changing so fast, their graphs don't reflect reality right now. So get your information from COVID Tracking Project, where you can start to see the death rate starting to go up, which you would expect given the way the hospitalization is going up and and of course the caseload is going up. We got a lot of interesting things to talk about. We'll get to that, but first let me get my guest in here. Is Dr. Scott Jensen. Dr. Jensen is not just a family practitioner, but he's also a state senator in the state of Minnesota. Susan, let's bring him in here. Can we do that? Mm-hmm. Here it comes. There you are, Dr. Jensen. Well, welcome to the program.
Thank you.
So tell me, for people that haven't seen your video that I caught yesterday and immediately reached out to you, to tell people what the content of that video was and what prompted you to do that.
Well, about 10 days ago, I received a letter from the Minnesota Board of Medical Practice identifying that they were investigating me for public comments regarding COVID-19, and they listed two allegations. The first one was that I was spreading misinformation when I appeared on April 7th on a Fargo Moorhead news program with Chris Berg. And that night, I guess it was perhaps one of the first times that anybody had talked about publicly the appropriate completion of a death certificate. And I made the comment that I felt the Department of Health in Minnesota had conveyed information that was misleading and ambiguous and really counter to what I've spent the last 35 years doing. So in the process of that discussion, someone evidently thought that was spreading misinformation. And the second allegation was very nebulous, and it simply said that I was guilty of providing reckless advice because I compared COVID-19 to influenza outbreaks.
So let's dispense with that first. So I'm guessing you sort of looked at the death rate from COVID-19 in Minnesota, or did you talk about the national death rate?
Well, overall, I think the case fatality rate for many of the epidemics we've suffered, they have some level of comparability. Clearly in 1918, we don't know as much about that one because we don't have as good a data as we'd like, and we didn't have any antibiotics. But certainly there's significant data out there that says 500 million people got the disease, 25 to 50 million died. You could put the CFR, the fatality rate, somewhere between 5%, 2%, 10%, somewhere in there.
Somewhere
but
there.
I think in 2018, we had in this country, we had 80,000 deaths, and that was a pretty strong year. And typically we see fatality rates around 0.1 in flu. And I think most recent data I saw from CDC regarding COVID-19, it was going to maybe end up being somewhere around 0.3. And then you look at MERS and SARS, and you're looking at, I think 10% for SARS and 30% for MERS. So I think to provide context so people can understand what we're looking at, I think we have to compare it to something. And it doesn't make any sense to compare COVID-19 to something like leprosy or tuberculosis or Ebola or gonorrhea, because it has no similarities, but It does have a lot of similarities to influenza.
And so what was your goal? What was your intention? I'm getting an echo here, Susan. What was your intention in making that comparison? What were you hoping to achieve by doing that?
I think I was trying to defuse fear. I was trying to let people know, this is a big deal, a novel virus. But the fact of the matter is, we've been there before. And if you think that we had 80,000 people die in 2018 in this country, and we didn't lock down, we didn't, if you will, give in to the fear, I'm trying to provide some hope and optimism, because I think there's room for hope and optimism.
Right. So you weren't saying don't lock down. You were saying whatever you will comply with whatever the state decides to do, but you're trying to help the individuals as a physician regulate their anxiety. Would that be a safe way of saying it?
Absolutely. And I think at the same time, Dr. Drew, I think I was trying to raise the alarm that for the Department of Health to come out and start coaching physicians as to how they wanted us to complete death certificates, that was problematic.
Well, I'm going to get to that. Let me get to that in a second, because that's to me, that's another topic, and it's kind of interesting, and people always ask lots of questions about that, so we'll get to that. But I got tagged with the same thing. But I could see back in the beginning of this epidemic that the press was beginning to whip up a frenzy. And what I kept saying was, shut up, just shut up, because I could see they were gonna take away the practice of medicine from the medical community. And indeed, that's exactly what happened. Now you have the New York Times editorial board saying, we demand a lockdown. We demand a universal testing policy. Who? What? They're not trained to have an opinion like that. They have no business saying anything like that. And that was the stuff that made me crazy. And let's be fair, we're not comparing to previous pandemics is only to give you a sense of how to regulate your emotions, not to say that we shouldn't take things seriously. It's just what I kept saying is, look at 2009. I got H1N1. It almost killed me. It was brutal. It killed 500,000 people, infected 1 billion people. It was serious, but you didn't even know it happened. The medical community took care of it. We did it. We did what we needed to do. So it's sort of meant to be reassuring, right?
Absolutely. And I remember seeing that, I think when you tweeted that, you said something like, would you please just shut up? And
that's what I was saying.
I remember thinking, you're absolutely right. When you leave this to bureaucrats and the sensationalizing media, they're not helping.
No. And I've been following Fauci forever, and I've been using his recommendations, and we actually used to have him do speaking and stuff. And I will defer to him always. I really will. And I'm worried that he's again starting to talk about lockdown. I'm not sure people will comply with that. I'm worried about that. But I will defer to his judgment. He's very conservative, but he's very keen. He has led me through 3 different pandemics, in my career, and I will defer to him. How do you feel about that?
Well, Dr. Drew, it was interesting because when I submitted my response to this Board of Medical Practice inquiry, I actually enclosed an editorial in the New England Journal of Medicine from Dr. Fauci in March, where he had, I think like in the 5th or 6th paragraph of the editorial, he commented that the way things were evolving, he thought that COVID-19 was looking very much like a seasonal influenza. And the contributing author was Dr. Robert Redfield. And so I felt like, okay, if Dr. Fauci can make these comparisons, I think that can be helpful to people.
And Redfield, who's also the head of the CDC, right?
Yes, he is.
Yeah. So yeah, and I feel like I was overly. I was so upset with the way it was going that I think I overstated my case, and I really made an explicit comparison, and that's why I apologize. We're not trying to make explicit comparisons. We're trying to educate so people can take into consideration the current circumstance given historical responses in historical past. So here we are with the death rate. Let's say the death rate is 0.8, right? And let's say the R naught is approaching 2, just for the sake of argument. It's a serious thing, and we got to take it very, very seriously. Who do we look to for guidance on this? How serious do we take it? How much do we cause unintended? So you and I are used to, let me put it this way. Here's the question I want to ask. You and I are used to making risk-reward analysis all the time. Every time we have somebody take a medication, I don't care if it's Tylenol or aspirin, we know we can harm our patients. Every time they cross the threshold of our office, iatrogenesis is always available, or untoward effect of one treatment causing an inadvertent effect in another area. We're constantly, we are steeped in do no harm. That is our thing. The people that are making the decisions have no ability to make those sorts of considerations. And as a result, as you and I would probably predict, we're seeing a massive increase in drug overdoses, alcoholism, diseases of despair, suicide. Who should we be taking our guidance from?
Yeah, I think we've got to lean into the medical profession. And I think that the medical profession needs to step back from the politicization of this, because that's not our best suit. We should be doing exactly what you said. We should constantly be aware of primum non nocere, first do no harm. And we should be looking for those randomized controlled trials to help us determine what's the best way to go. But I mean, I think you and I look for unintended consequences because of that. I remember when I think the drug Hitrin came out. I think it initially came out for blood pressure reduction, but it wasn't a very good blood pressure pill. But it did help treat the prostate. And so we watched that. And so all of a sudden we sort of stumbled onto a new way to treat urinary symptoms, but we quit using Hitrin for blood pressure.
Right.
Those are the kinds of things we do. Even today, if we look at something like school shutdowns, you and I are much more attuned to what are we doing to kids when they're growing up between the ages of 5 and 10 with everybody wearing masks, not going to school, maybe taking 6 to 8 months off of any formalized reading or mathematics program. How does this work out? Are we going to see problems 2 or 3 years down the road? And I think this is what we do. And I don't think you're going to see that from a lot of epidemiologists and bureaucrats and politicians.
Of course not. Well, the American Academy of Pediatrics has come in very, very, very clearly. They want kids back in school. They see they believe the unintended consequences will be profound. And I don't deal with pediatric age group, but I deal with parents, and I hear a lot of 8 to 15-year-old parents complaining that their kids are depressed, anxious, overwhelmed, who knows what. I mean, you tell an 8-year-old their world is going to come to an end and their parents are going to die if they step outside. You don't think they're going to have some trauma from that? You better think again.
Or take the flip side. When you tell an 8-year-old he can't see his grandma or grandpa anymore, and so all of a sudden 3, 4, 5 months go by, I think this is a profound impact on kids. A lot of the psychologists will talk about these impacting moments for children and how it does touch their lives indelibly. In our area, we've definitely had an uptick in suicides. Quite frankly, I think what we're doing to children almost feels to me like an unintended social experiment.
Yeah.
And we're going to end up having to wait on the other side of this to see what kind of consequences we've really put in place.
Yeah, the trajectory, who knows? And by the same token, again, in terms of how physicians think about these things, you take an 82-year-old who has, let's say it's an 82-year-old in male in decent health. He's probably got 2 to 5 years to go, and you want to take away 6 months? You just want to just take it away? That's it? We're taking away a third or a tenth, maybe, let's say at the best case scenario, but maybe a third of the time you have left. If I'm 82, I'd rather take my chances and get the damn thing and not bet on what little time I have remaining.
And again, if your time remaining winds down quickly, in this situation, what we've been doing in Minnesota, there's been a total lockdown in the nursing homes and the assisted living. So you're going to die alone. You're not going to have anybody there to hold your hand.
And again, in terms of time frames, again, the bureaucrats are not taking this into consideration. I looked into some of the data on average life expectancy after admission to a nursing home, and I found a range of about 6 to 22 months. That's your life expectancy once you're admitted to a nursing home. and we're going to take away either all of that or at least a fourth of it. So what? So I mean, it's just, no one is, and this is a major problem that I'm certain you're as concerned about as I am. No one in this country is realistically discussing end of life care, end of life wishes in a realistic way.
I couldn't agree with you more. I had an 85-year-old in yesterday who had been in the hospital for 21 days with COVID-19. And he and his family had said exactly what you said. Hey, I'm 85. If this takes my life, so be it. But I do not want to be on a ventilator. I don't want to put my family in a situation where they have to make decisions like that. And 3 times they were pressed to get on a ventilator. And every time the family said no because the patient was obtunded. And this patient came through it, and he came in yesterday, and he's back to running his business. He's feeling good. He said, if I would have gone, I would have gone. That's fine. But he said, I did not want to be on a ventilator. And I think, you and I think about those kind of things. When someone goes into the hospital and they're 85 years old, one of the most important conversations we can maybe have with that patient and their family is, where do you want us to go?
That's
How do you
right.
want us to go?
That's
Unfortunately, we learned so much from the docs in New York City that we did learn that, boy, we need to be a little more cautious with ventilators than we maybe thought we needed to be, because it wasn't working out so well. So I do think the rest of the nation has learned a lot from the New York City docs.
Well, and again, there's 2 pieces of data I keep pushing on this thread for our listeners, which is that I don't ever want to go to a nursing home. If I'm so neurologically or physically deteriorated that I need institutional support to get me through the day, which is feeding and turning and cleaning my bowels and things, just call hospice. Let's do palliative care. It's all fine. That's all cool. I don't want that extra 6 to 22 months in a nursing home. I don't want it. Thank you. That maybe I'll change my mind when I get there, but my wishes clearly now are that. And the other thing is, no one talks about the probability if you're in your 80s and you get on a ventilator, the probability of living a year after that is very low. And I have been through those years with people. They're horrible. They're brutal. So if you are sick enough that you need to go on a ventilator, and you do, the probability of living a year is almost 0. And that year, if you do live it, is a nightmare.
That's exactly right.
Yeah. So this is what people have to understand. And they just, when I started hearing this rhetoric, like, one death is too many, I thought, oh boy, now I can't make any decisions. If that's the criteria, well, what about the suicides, and what about the overdose deaths, and what about the all the other unintended medical complications because people aren't coming into the hospital? What do we do with those deaths, of which are skyrocketing right now?
It's funny you said that, Dr. Drew, because this morning I met with a group of 20-year-olds, and they have what's called a junior Senate program. And so they have a mock-up Senate meeting, and I came and I was a witness, and we were talking about this. And I said, we're not able to have real conversations in medicine because we've got these sound bites that are absolutely sucking the air out of the room to allow us to have a discussion. And the soundbite that I talked about this morning was, I remember when Governor Cuomo in New York said something about, well, this $1 billion we spent, if it saves one life, it's worth it.
Right.
Well, no, it's not. I told this group of kids, I said, my life's not worth $1 billion.
Yeah.
And if you want to spend, as a practicing physician, if you want to spend 500,000, maybe okay. But for heaven's sakes, don't spend $1 billion on me. I'm 65. Statistically, I'll be gone in a decade and a half.
Yeah. Yeah, I'm with you. And see, we're, it's interesting. Internists and family practitioners get to deal with death and dying almost more than any other discipline. I've been practicing internal medicine for 30 years, and one thing I learned early, I thought, when everybody else is done doing their thing and they can't do anymore, they just take off, and we're stuck. We're there helping people with the actual managing the reality of end of life, and you can make the end of life as dignified as anything else. Absolutely. And it's comfortable, by the way.
Yeah, and I think one of the conversations I'm hoping our society might be able to have at some point in time in the future is this concept of the QALY, the QALY. What is a quality adjusted living year worth? And I think we have to start being more honest, because quite frankly, we are bequeathing to the next generation and the next generation an almost impossible financial situation. And it's not just finances. We're not dealing with the reality of life. C.S. Lewis said, 100% of people leave this earth through death, and you can't change the number.
That's right.
I think
that's right. No, and a frame I like is if you don't want to die, you don't want to live.
Mm-hmm.
Pretty simple. Okay, so now Dr. Jensen is also a state senator, as we mentioned, in Minnesota. Do you think that some of the targeting was politically motivated? There's something about you being a state senator, I just by seeing you, I'm guessing Minnesota has a volunteer part-time state government, a state legislature, yeah, which of course California does not. We have a full-time legislature, so they do nothing but create more for us all the time. Do you think some of this was politically motivated?
Frankly, there's two complaints, and I think they're both politically motivated. They did not come from patients of mine. It was identified in the correspondence from the Board of Medical Practice that these were regarding public comments. For me and many of my colleagues, we're concerned because it's almost as if someone wanted to use the Board of Medical Practice and weaponize it in such a way that they would shut me up.
Well, that's what's happening. Isn't that, that's what, because that's what, once cancel culture learns it can do this, I'm sure there'll be a lot more of this, don't you?
Yeah, and I think we need to look at this because I don't get to see my accuser. I don't get to know who that person is. And quite frankly, it isn't just about, this isn't about me. This is a way bigger discussion. And that's why I appreciated you having me on. This is about anybody that has a licensing or regulatory board to which someone could make a complaint. They might say they don't like the color of your shoes. And if the board that happens to be in question is charged with responding to all complaints, then they've got to send you a letter, turn your life upside down for at least a few days, put you through the process of maybe taking 30 hours out of your life to present a response. This is hard.
It is hard. I worked in a psychiatric hospital for several decades, and that's a common environment to get, because there's people that have distortions and anger and all kinds of things, and they will act out on the physicians. And so it's common for there to be board complaints from a hospital setting, from the psychiatric hospital setting. So I got ensnared on a couple of them, and they were, I mean, beyond, they're as outrageous as this, right? And yet you still have to go through the process and review records and give a justification and feedback and responses, and ultimately a tribunal if it keeps going. Let's call it what it is. It's a tribunal. Who makes up the group that's evaluating these issues in Minnesota?
Well, in Minnesota, it's a body of 16 people. 5 of them are governor appointees. So you always worry about that. You wonder, well, is it going to be a group that might have a partisan slant? And then you've got 11 others. And I've tried to stay away a little bit from some of the details because I don't think it's appropriate or fair for me to try to ask for special privileges. Yes, I'm a state senator. Yes, I make a lot of public comments, but I'm a physician, and I got an inquiry from the Board of Medical Practice. I have not hired a lawyer. I know maybe that's naive and foolish on my part, but it seems to me that I should walk through this just like anyone else would.
The reality is you have to. That's the reality. I don't think you have any other option, really. And you said in your video that, this could happen to anyone, and it will. It just will. It's really kind of wild.
I think, Dr. Drew, if I could just say, I think one thing people might not realize is, as physicians, especially primary care physicians like you and I, we are so invested in trying to do everything right for our patients.
I know.
People realize how deep it pierces when our professionalism and the thing that makes us stay up at 2 o'clock in the morning reading about a case so that we can maybe do a better job for a patient the next day. We're not making widgets.
No.
We're dealing with life and death, and we've chosen to do so, and it captures us. It takes us over, and we're okay with that. We work 60 hours a week. We work 80 hours a week. We do house calls. We do subordinate our family's importance at times because we elevate our patients' importance. This hurts.
Yeah, I know. And I feel so deflated, especially this whole pandemic and everything that's gone along with it. The first couple of decades I practiced, I thought what I was doing was so important, really important work. And I feel now like the New York Times editorial board, they think they can do a better job. It's really deflating. It's very difficult to do the work we need to do. And the patients are the ones that are going to suffer more than us. Anyway.
I agree totally. I think the New York Times, they had a front page article about me a month ago. And I think that, quite frankly, I lost some respect. I think that at the end of the article, they took a shot at me. I had been in a Zoom call at the end of the day around 4:00 in the afternoon, and I had two meetings overlap. I had a committee meeting that ran a little long, and then I had another engagement with my campaign treasurer on the golf course. And so they saw me on a Zoom call in a golf cart for the last part of this meeting. And I'd been working 9 hours that day doing Senate business. And I mean, really? I know people who do Zoom calls in the bathroom, in the kitchen, babysitting, in the car. And I just thought, if you're really interested in reporting the news and helping people understand what we need to understand about getting through this COVID-19, there's a more constructive way to do it. When the media decides to play gotcha, I'm sorry, I lose respect.
That's all they play. There's something called, you ever heard of something called Gelman Amnesia? You never learn how distorted the press is until they do a story on you. And there's a version of that called Gelman Amnesia. Dr. Gelman was a famous physicist who recognized that every time he read the paper when they reported a story about physics, they just didn't get it. They just distorted it, and it was wrong, and it was off. And then he'd go on to read the rest of the paper and assume the remainder of the content was all accurate and good. When in fact, it's all bad. It's all distorted. And you learn it when they do a story about you. They just nuance the language. They change. It's just, you can't even believe it when you see it. So
I think
go ahead.
I think that's part of the reason why some people were so inflamed with me is some of the original interview on April 7th, there were different groups on internet that took clips of it and they used it to fuel a different perspective. It might have been a perspective that was more conspiracy oriented or something like that. And people asked me about that. Well, and especially after I'd been on Fox News with Laura, and they said, well, don't you feel terrible about the fact that some of the things you said are showing up on other parts of social media? And I said, well, in this day and age, how do you possibly control that? I didn't even know the names of the websites that people were using. I guess there was some Russia Today news source that had put me on their news over in Moscow. How would I possibly manage that?
Yeah, I know. And by the way, and people always, will ask questions like why physicians don't change this and why put up with it. It's because we're too busy with our patients. We are too busy to spend what the time needed to change these things. So we never come to our own defense.
Very true.
All right, let's talk about the death certificate thing. I'm fascinated by the general topic on death certificate interests me because I've been complaining about, at least how it goes out here, death certificates. First of all, in medical school residency, we're never trained how to do it. No one actually sits down and says, here's the proper way to set a death certificate. Secondly, not every time, 80% of the time that I fill out a death certificate that reflects the reality of what happened, I get it back from the coroner or somebody saying, this will make it a coroner's case, or we can't accept this. And I end up backing away from the actual reflection, the actual sort of sequence of what happens. The closer I get to the heart stopped and there was cardiopulmonary arrest, the closer I get to that, the more likely I'm going to be able to have an acceptable death certificate, which of course everybody has that as their cause of death. But whether or not it was cytokine activation with septicemia and diffuse clotting with lung infarcts and maybe there was empyema. And then there was cardiopulmonary arrest as a result of the failure of treatment. There's a bigger problem here than just COVID, I think, when it comes to death certificates.
I think you're right. I think death certificates have been fraught with problems. Yeah. And I think the training that we receive is certainly not very formal. I think what happened in this situation was I was flipping through emails on Friday, April 3rd, I think, and I saw this email come from the Department of Health, and I was going to delete it because I read a lot of stuff from the Department of Health, but there was, I think it said vital statistics or something on it. And I thought, well, I better look at it. So I flipped it open and glanced through it. And at the bottom of the page, my heart sort of sank because it made some comment about, we are allowing you to go ahead, and if you assume that COVID-19 caused a death, or if it contributed, go ahead and put it as a cause of death. And I thought, well, hold it, that's not right.
Yeah.
The underlying cause of death is very important. And if I have a patient with congestive heart failure who's failing and is in hospice, and while they're in hospice, they continue to see their heart failure, and now they have end-stage heart failure, and I've got them on oxygen, and they look like they're a day or two away from dying, and all of a sudden, someone says, well, we've got COVID-19 here in the hospice. Whether or not we test for it, we're supposed to put COVID-19 down on the death certificate, or if we do test for it and it's negative, we can still put it down. But as far as I'm concerned, even if I did test for it and it came back as COVID-19 positive on a PCR test, I still wouldn't put COVID-19 down as the cause of death. The cause of death is supposed to be the initiating event in a sequence of things that bring about the demise of a patient. And the initiating event in that situation was congestive heart failure, moving into pulmonary edema, moving into respiratory distress. And if COVID-19 happened to enter the scene in the last 24 hours, that should go in part 2 under a contributing condition. End of story.
I sort of trust our peers to kind of push back on that. What percentage of the data do you think is adulterated by that phenomena?
Well, that's a hard one. I think that when I look at Pennsylvania and I see the coroners blocking there, and all of a sudden Pennsylvania saying we're taking away a couple hundred COVID-19 deaths because they weren't really COVID-19. And then in Colorado, we saw the same thing happen. And then in Illinois, I can't remember her name, Dr. Akifi or something. She's the Department of Health director. She comes out and says something like, well, listen, just because we put COVID-19 on the death certificate doesn't mean the patient died of COVID-19.
Right.
That's just because they had it.
Well, so, but there's two different things, though. One is we, as epidemiologists, will, as a matter of convention, take any mention of concomitant COVID-19 in our death data. And that I don't object to. That's a convention, and you want that in the data. That's the decisions you make. It's just like making any other decision in terms of data collection. But requiring physicians to distort the death certificate, that's a different matter. It's really different. And I feel like our peers will push back on that piece, but I don't know.
I've heard from hundreds of physicians after I did the video on Sunday, and they're saying exactly what you're saying. I mean, they're saying this is going to bastardize the statistics we have. We're going to have in 2020 so few people dying from coronary artery disease or congestion because they're all dying of COVID-19, and we won't have a clue what we're doing. We cannot let the bureaucrats, the epidemiologists, and the politicians influence this. And I think that it may be 10, 20%. Now, on the other hand, I would say this. Certainly, we're undercounting cases because we know that for every documented case, there's a bunch more of unidentified cases.
Right.
But when it comes to COVID-19 deaths, I don't even want to comment on the overall thing. I just want to say that I think physicians are being pushed into putting COVID-19 in situations where clearly the patient died of something else.
See, that's not good. That's going to affect the epidemiology and our understanding of all the other diseases that people are actually dying of. Yeah. And God knows maybe funding for the research with those diseases, and who the hell knows what the consequences might be.
Well, it wasn't too long after, I think, New York inflated their number because they decided to start looking at that delta between what the typical number of deaths was during a time period versus this year, saying, well, gee, this year is higher, so that number may well represent COVID-19 deaths that weren't picked up. So then when they did that, I think within 2 or 3 days, maybe it was a week or so, we saw U.S. congressmen from New Jersey and New York talking about how important it was that those 2 states get a larger allocation of federal dollars from the CARES Act because they were dealing with more COVID-19 cases and having more COVID-19 deaths. Well, this undermines the trust in the rest of the nation and certainly the public at large.
Yeah. So let's talk a little bit about the future here and our worries and wishes and that sort of thing. It's pretty easy to predict that there'll be an uptick in cases when people begin moving about and when people congregate by the tens of thousands in the street. There's going to be an uptick in cases. There just is. particularly when people resist measures that reduce transmission, like distancing and mask wearing and that kind of thing. So it's inevitable. So here we are. It's happened in most states. I want to ask, which makes me think of another thing, which is I'm really in favor of local management of this outbreak, because for me, the idea of a federal policy, what city are you in, Dr. Jensen?
I'm in a city called Chaska, which is about 30 minutes.
So if Chaska is not going to have the same epidemiology and needs of Pasadena, where I am, and Los Angeles, which I'm adjacent to, which is not going to have the same as Shreveport or Ketchum or Casper, Wyoming. I mean, we are a giant country, and to have one universal policy, I think it would just be a disaster. It's really the counties that must manage it, and then the state coming in to assist the counties. Do you agree with that?
I do. In Minnesota, we're a big state geographically, and we have 87 counties. And I mean, we had some counties that didn't even have a case of COVID-19. They never had a death. And they were being, if you will, made to behave by the same rules that were going on in Minneapolis and St. Paul, where the great majority of cases were taking place. Even, if we take it in terms of lockdowns, restaurants, workers, what's essential, what's not essential, but even schools. I mean, there's no question that many places in this country could have kids back in school with very little concern. Now,
Right.
Granted, there might be other places that have more concern, but local control of the various mitigating things we want to do absolutely makes the most sense. And as a policymaker in the Senate, I see that over and over again.
Yeah, and even a nationwide testing policy, I started thinking about that. I'm like, I don't know about you, but I've seen some kind of, there's a part of the testing story that's not being discussed, which is, I don't know if it's the accuracy of the test or the way the virus expresses itself, but just because you have COVID doesn't mean you're going to have a positive test. And if you do have a positive test today, you still may be sick tomorrow with a negative test. It has weird and nefarious time courses to it. So the only way we're able to get the information we want from, let's say, nationwide testing, if we had infinity resources, would be to test everybody like every 3 days for 3 months in order to really get the information. So this idea that we'll test everybody is false. Would you agree?
I do. And I think that we need more input from physicians, and I would say specifically infectious disease doctors that can really help us. I think we're a little slanted towards bureaucrats and academics because they're not the ones that are seeing the 2009 swine flu. They weren't there with the 2012, the MERS, and the 2014 Ebola, and the 2018 robust influenza season. We're in the trenches, and we watch how these things behave. And we know that in the middle of Minnesota, it's going to be different than at the very northern aspect of the Canadian border, where it's going to be a different presentation. And it's almost like we've taken medical science, chucked it out the window, and said, we're going to bow to the, if you will, the altar of epidemiology, fear mongering, and we'll let physicians once in a while weigh in. It's really unfortunate because we're paying a price.
Hang on one section here. Yeah, we are paying a price for being, for letting go of our profession, really is what it is. We've sort of let other people step in, or we've sort of stepped out. But so the death rate is lower now. The case rate is up, as I said. So we predictably have had a tick up, and certain states are having an increase in hospitalization. What do you imagine is going to happen with the death rate going forward?
Well, I think the more cases we have, the more data we get. I think we're going to see. Right now, we don't have the ability to measure, if you will, that whether or not someone's had it unless we have a positive antibody test. And if we do that, we really can't rely on that completely, because we know that there will be a certain number of people that will have immunity to COVID-19, but it won't show up with an antibody. They may well have T-cell cellular immunity. It may not be a humoral immunity. So I think we're going to slowly get better and better at identifying who's had it, who has an immunity to it. As we look at that number, we're going to be struck by how big it is. I also think that when it comes to our death rate, yes, we're going to continue to have some death, no question about it.
Yeah.
But it makes sense to me that the first blush with this disease, this novel virus, it makes sense to me that it will hit hard that most vulnerable population. So we've had 130,000 deaths in this country. Well, those 130,000, back to your point earlier about people that are living in long-term care facilities, these people were over 70, over 80, over 90, multiple underlying conditions. They were, unfortunately, and I don't mean to be insensitive, but they were almost easy pickings for COVID-19.
Right.
We're starting to see it now. We're seeing the 20 to 50-year-old population get it. Many of them are skating through it. They barely know they had it. And so I think we're going to see more and more cases. We're going to see the death rate level off and slowly drop. We're certainly seeing that in Minnesota. And I think that we're going to start to say, hey, we will move through this. This is not going to cause an extinction of humankind.
No.
We get a little bit more, okay, this is something that happens. And I'm hoping that we can learn so much this time around so that the next time we will deal with the pandemic better, because there will be a next time.
I'm trying to address a question on my chat thread here. Hang on a second. Why months later? I don't know anyone sick. I'm in Connecticut, a hotspot. So your question, Jeffrey, is why you don't know anybody with this condition? It's because although the numbers are large, our country is enormous. You have to understand that 100,000 out of 350 million, you're not likely to encounter those people, particularly the fact that a lot of it is isolated in nursing homes and other kinds of environment. But that's to answer your question. But it is starting to get into the younger population now. And locally here, I can tell you that the people who are coming in the hospital are younger now. And I'm concerned we're not even having a rational conversation about racial groups and how it's affecting them, because it's different in different regions. And all you hear is that African Americans have been disproportionately affected, which in New York City, they were clobbered. But out here in Los Angeles, they're actually doing very, very well. And Hispanics are getting clobbered. We need to explain that. We need to understand why are we doing well out here? And if there's some active something we're doing, take a bow and let's use it across the country. But we're not even, I don't even know why we're not looking at that. It's very frustrating. Any ideas?
Well, I think, Japan has had a pretty good track record. And I have to ask myself, is there something about the DNA in a Japanese person that may be protective? If you take an African American, certainly they're far more susceptible to sickle cell disease. But if they're not homozygous in terms of having both genes be sickle cell traits, then they'll be a carrier. They'll be, if you will, a heterozygote, and they will have a protection against malaria. If you go back to Jesus' day, there was probably 90% of the population that couldn't get leprosy if they put it on their Cheerios in the morning.
Right.
And I think we're not realizing that there is this thing called innate immunity. The person who put the question forward to you, it's very possible that he or she is already immune and just doesn't know it.
Right. And we haven't answered that question yet. Right. And that is the next. So that was going to be my next question, which is, so we're in an uptick. I'm fearful that in some areas it's going to be an accelerating slope. The so-called delta is going to increase, and we're going to have a lot of people sick. And I'm worried about it. Do you have any ideas what we should do? And I'm asking an unfair question because that question should be answered based on local epidemiology. We've already established that. But do you have sort of a range of what you think would be reasonable responses?
Well, I think I'd start off by saying that I think local measures, local areas should be able to decide as much as possible. I think that if we look back to the centuries of mankind, we've been having epidemics for a long time. And if you look at what we learned from the Black Plague and things like that, I think the common sense stuff is the most important stuff. I think we should dump the phrase social distancing, because I think the idea of social isolation is killing people.
Yes.
So physical distancing is a good thing.
Yes.
I think we could have an argument about whether 8 feet, 6 feet, or 3 feet is the ideal measurement.
Dr. Jensen, here they like saying shelter in place. You must shelter in place. That's a term used for an active shooter situation, like a war. I mean, I could not imagine a worse way of communicating medical information, but they're threatening going back to that out here in California. So, yeah.
Bad idea, because at some level we have to appeal to personal responsibility. We have to, whatever we do, we have to remember what is human behavior and are they going to be able to comply? I think most people want to do the right thing. Nobody wants to kill someone else's grandma. But I think that if we look at the common sense stuff on masks, quite frankly, I thought Mike Osterholm, who's a prominent epidemiologist, had a very good video on June 12th, and he talked about it. I think if you actually look at the physics of masks, the N95 makes the most sense. But I think most people need to understand that N95 mask has an exhaust valve on it. So you're really just protecting yourself. You're blowing out air onto other people that isn't filtered. But getting back to what should we do? I would say physical distancing, 3 to 6 feet. We need to keep our hands away from our eyes and our nose and our mouth. And that's one of the worst things about masks is I have never seen people play with their face as much as when they have a mask on.
Well, we need some more science on that, because I touch my face a lot. I've noticed with the mask on, I touch the mask, but I don't touch my face. Now the question remains, is that the same thing?
Well, I think Dr. Streeck from Germany did an interesting study. I think he was the one who was involved. They had active COVID-19 patients coughing through masks.
Yeah.
And then they tried to harvest the virus on the inside of the mask and the outside of the mask. And in one study that I was reading, they harvested more virus on the outside of the mask than the inside of the mask. So I think that if we're going to do it right, we really need to be careful about keeping our hands away from our face, and we need to not touch the mask.
I agree with that. That was just from transmission of all infectious disease. That's a good piece of advice. But I did some digging into the 1918 flu, and there was a number of physicians during that outbreak that really felt the mask made a massive difference. They felt that was how they were able to go in and care for the patients and not contract it. So there was something about it that was working even then. But I like the idea of physical distancing rather than social distancing, because I'm not sure people will comply with it if they ask for it this time. So that scares me. So I don't know if you agree with me, but in terms of public health messaging, I've noticed throughout my career that if you tell the public, particularly the younger public, if you exaggerate or say anything even slightly hypocritical, they stop listening to you completely, right? Like I call it reefer madness, right? Because they overstated the cannabis thing. Sorry, that's it. We're not listening to anything about cannabis ever again for 30 years. Same thing with HIV and AIDS. We really were aggressive in the messaging. Now I can't get anybody to wear a condom because we were too aggressive 30 years ago. And now my fear is they're being so inconsistent in their messaging that people are just going to stop listening. And I think we're kind of there. Do you agree?
I think we are. I think that we've absolutely fractured the public trust. And I think that's part of why the video I did about my board of medical practice making an inquiry, it just went viral. I mean, I think 10, 12 million people have seen it, and the outpouring of response. People are frustrated. They don't believe it anymore. They want to do the right thing. I remember when I was in my training, I had a patient and she was Hmong. And I remember we had to transfer her to another hospital because she was having difficulty in her active labor stage. And I remember she went to this hospital and the docs there just hammered at her. She had to allow them to do a C-section. They had to, and she said, no. And just hammering at her. Finally, they said, well, if you don't have a C-section, your baby's going to die. Well, lo and behold, 20, 30 minutes later, the head twisted, turned. All of a sudden, she has a normal vaginal delivery and the baby's fine. But for the next 2 years, when we tried to tell someone we really needed to think about a C-section,
right,
we were trying to push the snowball uphill because we had compromised our integrity. And we have to be really careful what we say about COVID-19. Dr. Fauci is a very bright man, but there are times I wish that he would just say a little less or acknowledge that we just don't know. No. Sometimes I think he weighs in. I remember when he came out and he said, there's no way that we can get a vaccine unless it's 12 to 18 months down the road. Well, then we're finding out that we may be using some human subjects in September.
Yep.
And that
I've signed up, by the way. I signed up for it. Yeah, I'm ready to go. I can't. What's that?
I think physicians, our general approach is being careful and methodical. We don't need to tell patients that we know more than we know. We can be upfront with patients and say, we're not sure, but these are 2 approaches we could take. And patients expect that.
Yeah. So it's two words. And again, this is my own criticism of myself when I was trying to regulate everyone's emotion, which was every situation has to be approached with humility. And if you ever allow hubris to creep in, you're done. You're done. And to demand a C-section of a patient is a bit hubristic, right?
Absolutely.
Yeah. So here's my concern as it pertains to where we are, given everything we've just said in terms of the lack of trust, the lack of listening, and the fact that things are ticking up. I think the death rate's going to go up again. It just has to. And my fear is that people aren't going to listen. People are going to resist distancing and masks and things. And this thing could really run a bit. And that by itself doesn't scare me because I think most of it will be mild. We know that. Somewhere between 96 and 99% of people do just fine. Or at least certainly 89+% do extremely well. So it running more doesn't bother me, but my fear is it's not a genie you can put back in the bottle. And we may not be happy with where we end up. And people are not they can't realistically see that, I don't think, right now.
I think that's right. But I do think the science is showing us that we sort of have a pretty good idea about that largest group of vulnerable people. Now, granted, this COVID-19 has a nasty, wicked streak where it'll hit someone that should never have been hit hard, but it will.
Right.
But you're right, Dr. Drew. I think 90% of people will skate through it. Some won't even know they had it. Others will skate through it with minimal symptoms. So we're looking at that other 10%. And of that, we're going to have a very small group that has a problem with COVID-19 in terms of potentially being lethal, unless they're over the age of 70 with multiple underlying medical conditions. So I think we need to, I agree, the genie, I think, is already out of the bottle. We have millions of cases. So I think we need to focus and pivot on, okay, the vulnerable group, we need you to do everything you can to take care of yourself. That may mean self-quarantine. We're going to support you to the max. What can we do to make your life as rich as possible? And we will be there. We will put groceries on your doorstep. We will do what we need to do. But in the meantime, I think we have to look at those other diseases and deaths that come from the desperation of a lockdown, losing dreams, spending your life savings within 2 months and trying to raise your children. I think of some of these husbands and wives with 3 children in a small apartment.
Oh my God.
They're going crazy.
The health consequences of forcing people into poverty, into unemployment, and just into a world where they can't see the future. And if they're prone to substance use, it's on, man. It's the mental health piece is just, I don't even want to think about what the next year could be like. If we don't give people need social contact and they need meaning, and we're depriving them of both. That's not a good combination. And then we're not treating the mental health piece. We're letting that sort of run out in the streets in an open air asylum, at least out in this state. And so,
what we're doing, I think, with mental health is we're paying lip service to it. I mean, you can say, oh no, we're absolutely advocates for mental health. But if you're not going to compensate psychologists and social workers and licensed therapists, you're not going to make any headway. We need to get some of these patients in for that first 45-minute visit where they can be told that they're okay. And the fears and the doubts and the obsessions that they're having, that's part of being a human. And that it's understandable. We're living through a time that we've never lived through before. My wife asked me the other day, she said, why did 9/11 bring us together? And why is COVID-19 fracturing us apart? Yeah. It's a big answer. It's a big answer with a lot of nuance and a lot of flavors. But we need to tell people, you're okay. And let's talk about this. And let's get through this because we through this.
Right. I mean, I think that is a great place for us to sort of end this conversation, which is that there's a way to fight. There's a way to not be a victim. There's a way not to be passive in this. And as we can protect ourselves and we can be rational. And if we get sick, there's a lot of treatment available. We can really, move forward with, and the word that I've not seen anyone use is we can all courageously together fight instead of hiding. And it just seems like the opposite of the kind of mental attitude we should have as we push through this. And it's because there's out here, there's no leaders leading. There's nobody inspiring us, and there's no one with the judgment to help us navigate in a healthy way. I thought Governor Cuomo did a pretty good job with that in New York. He was certainly trying to do that, and for the most part, I really appreciated the effort and the approach he was taking. He though too had no experience with any of this and was saying things that you could look at and go, you're being ridiculous. You're being absolutely ridiculous. You're wrong. But good for you for hanging in and leading and doing what you're supposed to do and making tough decisions. These are not easy decisions for the leaders to make, and they're not supposed to just follow the experts. They're supposed to weigh what the experts are telling them against the consequence of their decision. So,
and if I could add, Dr. Drew, I think what you said before about humility would go a long ways. I think those policy leaders having a touch of humility will go a long way. And then I think we could lead. Physicians can lead. What we need to do is, I think we need to be, if you will, willing to have disagreements and willing to have discussions. That's what we do in medicine. When we would have grand rounds, we didn't go into grand rounds expecting a unanimous opinion on what the diagnosis was.
No.
And we're holding people in contempt if they don't agree with it. We need to move away from that. We need to let one another breathe, and we need to be able to talk about these things.
We used to. I don't know that the younger ones are tolerating it the way we used to get into it in the day, but we had something called pimping, which is we made sport of humiliating each other with our. We would go at each other until when I was training physicians, I would go at them until they ran out of knowledge. And then I would go, well, that's where you need to start working, right there. That's the limits of what you know about this. Keep going. Go back to the books this afternoon. We'll talk about it again tomorrow. And then we'd all have lunch. It was understood that this was to make us better, to make us grow. The people I was training were going to go out either with a scalpel or a prescription pad. I took that responsibility very seriously, and as a result, we exposed ourselves to all kinds of challenges, and that made us grow.
And I think the other thing that happened with your technique is oftentimes you helped that medical student or resident realize that they knew more than they did. You took them down a line of questioning in almost a Socratic method.
Yes.
You got them to realize they knew more than they did, but you brought them to their endpoint and you intrigued them, go out and learn more.
Yeah, and not only that, if it was bottomless, if they did know a lot, it would inspire the other residents. They'd go, oh, look what he knows, she knows. I want to be like that. And so there's layers to this, and the idea that we have to cancel people, it's weird. It's a weird Great Awakening religious impulse where sinners are unredeemable and must be. I'm sorry to say this, but we're having Bonfire of the Vanities and auto da fe without flames today. We do it in social media. It's the same thing. You don't recognize it because you're not seeing the flames. But immolation is alive and well, guys. Every time you try to cancel somebody, it's the same impulse.
Yes, it is.
All right. Well, Dr. Jensen, thank you for running the ropes with me here. I appreciate it. I knew this would be a good conversation. And, I'll consult with you should I have to, deal with my own board of medical quality assurance. Like I said, I've been there before, and it requires a lot of paperwork and a lot of time. And it's a big waste, generally speaking. It's a gigantic waste. And I'm sorry you had to go through that. But I really admired the attitude you took. And should I encounter anything, I may want to look at your 70 pages of references. I thought that was a nice touch.
Thank you very much, Dr. Drew. And I do want to honor the process, and I want the Board of Medical Practice to have some time to go through my response and the attachments. But I would, at some point in time, I would like to release those so that public conversation that's taking place can continue, because this isn't just about medicine. This is about a regulatory agency being weaponized. And at some point in time, we've got to see, somehow we have to stop that, because in our society today, we have a willingness to engage in a raw hostility beyond what we used to. We grew up with Andy of Mayberry, and we're not living with Andy of Mayberry anymore. We're now living in a world of anonymity. And if I'm behind a keyboard and you can't get at me, I'm going to rip and tear however much I want. And in that situation, we're probably going to have to make some modifications.
Right. It's mobs, right? It's mobs and their behavior. And if you don't know what auto da fe is, look it up. And bonfires of the vanity, look it up. And you see if you don't think that's exactly what's going on right now without flames. It's being done electronically. And that's very, very dangerous. It really hurts people. It really is harmful to people. And there may be ways to harness the impulse in positive ways, by the way. Oh, my audio went away. Susan, did you do something there? No. Okay.
No, are you still?
I don't know.
Can't hear
Tom
anything?
Cigar said no, and I don't know. That may be on his end. In any event, Dr. Jensen, you've been very kind with your time. I will let you go. I think I covered everything. Do you have any questions for me?
No, I just want to thank you for your commitment to helping people not be fearful, try to understand. When you talk things through, people say, okay, it's okay for me to think for myself. And you and I both know that if people get fearful enough, sometimes it paralyzes the brain. So I really appreciate you having the conversational tone that you bring to the topic matter. And we're going to get through this. Thank you.
And I want you to know that I saw your video yesterday and I thought, oh, there's a like-minded physician. I just knew exactly. I know your fund of knowledge. I know how you practice medicine. I could see it all right in that video. And so that's the other reason I wanted to speak with you. And that you're right. This will happen to many in all likelihood before we get this thing under control. So it's important for our profession to be aware of it and deal with it.
Thank you.
All right, my friend. We'll talk to you soon sometime. If you need me, you've got my DM. You can do it anytime. Get a hold of me anytime, okay?
Good luck on the Ingram angle tonight.
Oh, yeah. Say hi to Laura for me. All right, Susan, let Dr. Jensen go.
Okie doke.
And I emailed you a video I want to air. Did you see that there? I think you might have already had it.
Send it where?
To your email.
Okay. Hold on.
Yeah, I think you already have the video. It's that green mask video. I want people to see that again so they can get a little understanding of why I am such a mask advocate.
Also, I want to mention that we have Robert Henderson in tomorrow.
Oh, good. So Rob is the philosopher from Cambridge University who's reason I wanted him back is he's been tweeting a lot lately about human nature, and that is what I'm interested in. Before, he was sort of doing more the nature of morality, but now he's getting sort of more into human nature generally, and I want to talk about it. I want to see what's going on.
You sent it to my email, right?
Yeah. If you want to know, I keep talking about mobs and mob action and stuff. We are fundamentally, this is all, we've been through these cycles before in history. And it was Jean-Jacques Rousseau that inspired it and ends up in the French Revolution. So Rousseau is the French Revolution. Thomas Hobbes, Rousseau felt that we were all just perfect human beings and we ruined ourselves by entering a social contract. He's everywhere free but always in chains. And that's the basic construct, which is that society ruins us. And Rousseau became the rallying philosophy for the French Revolution. You see where that went. The opposite of Rousseau, in my humble opinion, is Thomas Hobbes, who has took the position that without society, it's a war of all against all, and life is, solitary. Wait, I'm going to get you the... Oh my goodness! I normally know Hobbes' little aphorism about solitary, brutal, and short.
Here's the video.
Okay, hang on a second. So, and when you believe that it's a war of all against all, then you end up with a Cesare Borgia or a Henry VIII. Neither extreme are good. It's navigating in between, representative, decentralized, balanced government. That's where we want to stay. So that when everyone talks about undoing our institutions, be really understand your history and see where it has gone bad in the past. Let me see if I can come up with Hobbes again. Hang on a second. Brutal, nasty, solitary, brutal, and short. And I forgot one of them. Solitary, nasty, brutal, short, and maybe I'm gonna look at the restream, see if you guys are smarter than I am. Thomas Hobbes, War of All Against All. If you look All Against All, you look it up and you'll see the little 5 words that he always. Solitary, nasty, brutal, and short. There's one word before that, though. Okay, let's look at the video while I watch you guys on the chat.
Let's see if it'll play.
Okay. All right. So there is, yeah. So this is an MIT sort of setup, and it gives you a sense of what happens when you cough or talk, right? So that's what's happening when you breathe hard and cough and talk. And that is what is concerning me. It's the water droplets that carry the virus. That's a cough. Okay. And it's not the virus itself. It's the virus catching a ride on the water droplets. So when people say the masks don't contain the virus.
Are we allowed to play this?
Oh, I don't know. Yeah, you better stop it. It's Today's Show, isn't it? Maybe it's tomorrow thing. But can you find the part with the mask?
Yes.
we can play that little part there.
No, I know. If you do little pieces.
Yeah. So the part with the mask, and you'll see how different wearing a mask is than wearing a bandana versus.
Oh, this is the Today Show.
letting
There's
things
another one
fly.
that's just the.
Yeah, I know. I sent you the wrong one. I'm sorry.
Here it
about
is.
that.
I think I found. Okay.
If we can just let's look at the effect of masking. Here's masks. Well, I think
That's no mask.
That's no mask.
Wait, I just had it. A second.
Okay, that's no mask again. It's all no mask. Okay, anyway. The point is, you'll notice they're all wearing masks, all the researchers there. The mask holds it all right here. You'll see it comes out and goes up. It can go places, but it's essentially, in and around your own head.
Here it is.
Solitary, nasty, poor, brutish, and short. Thank you, Jason. Solitary, it's actually solitary, poor, nasty, brutish, and short, which is true. I mean, that's humans without society are woefully unable to survive. They're alone. It's nasty. They don't live very long. It's brutal.
I think we're allowed to take that stuff off the news. So.
Solitary, poor, nasty, brutish, and short. But if you strictly have that belief system, oh my goodness, they're saying 25 feet. Wear the mask, everybody. Just wear the damn mask. Is that if you really believe that exclusively is the state of humanity, then you want somebody strong to hold it all together, and that ends up in dictatorships and things. So that's not good either. So it's a balance, everybody. That's what we're looking for. And within the balanced government, we got to have real leaders. And I just tell you what, I'm not sure the leadership is. It needs to be local. It needs to be, in each state, in each county, in each city, and it's very spotty right now, as you all are aware. Okay, so we want to thank Dr. Scott Jensen for being here. Tomorrow we have Rob Henderson in here.
Banner back up.
Rob Henderson again.
I woke him up at 2:30 in the morning
he's in London. Oh boy, well done.
He responded. He's very excited. He said that cancel culture is worse than ever.
Hey Jason, don't worry about the order. You got me the words. It rings in my head in the right order because I've read it so damn many times. Solitary, poor, nasty, brutish, and short. Although today my aging brain could not pull it up, which is deeply disturbing. Why not eye protection? Eye protection, if you're around high concentrations of volatilized secretions, absolutely eye protection is good. That's why people wear the shield and a mask. Matthew, I forgot to tell Dr. Jensen that a lot of people were thankful he came on, and we thank you for the comments. We saw them. It was a good episode. He is a good interview, and he's a good guy.
Let's give a shout out to Red
antibodies
Hawk.
are being actively studied in phase 3. So I signed up for that trial too, by the way, but I think it's only for people that are sick. So put that up again, Susan. So when I travel, I carry those 2 wands, and absolutely, I am a big fan of the UV light for any seats you're going into or aircrafts or anything. The thermometer is available, and of course the Sand Mini. You can call 8664 Red Hawk to get any of this stuff. The Sand Mini is for people that are insulin syringes. If you were someone cleaning up the city's needle problem, this Sand Mini would be your device. You don't have any more biological waste, and and no more needle sticks too, which is
I think you get a
important
discount
thing.
if you go use a code word Dr. Drew.
Big important thing to deal with the needles. But anyway, if you live in the city like Los Angeles, you know that. Well, I'm sorry that I lost you. Who is that? Maria. You disagree with Cuomo, how Cuomo handled it. I didn't agree with what he said. I agree with his approach, right? Some of the stuff he said I disagreed with vehemently, but I appreciated his firm, steady approach and what he was attempting to do. I'm just looking at the chat on Restream so I can... What will I go through during the trial? I don't know yet because they have not contacted me. I signed up for it. Somebody sent me a link and I just went right in. I'm hoping to get the vaccine because...
Did you sign me up?
No, you have to sign up for yourself. And they won't let you sign up twice.
How do you do that?
Who sent me the link? All right.
Send me the link.
Let me see if I have it.
I have to be with you. If you're...
You have to be with me?
Yeah, I mean...
if I get sick, you have to get sick too?
Well, no, you won't, and I will.
I don't see where I got that from. Somebody, I just went right to it. I can't see where.
Oh, well. Worry about it later. It's
yeah.
fine. I'll be here all day.
Which vaccine will I get? I'm hoping the RNA vaccine, but I don't know. I just signed up for they have this general sort of pool for phase 3 trials.
Amy.
What, set your wife up? Do you like that one? I didn't.
It's okay. He's always very generous.
Well, I'm willing to sacrifice myself. I'm not willing to sacrifice her.
Oh,
and she'll have such a good time when I'm gone. So, when a sizable percentage of the population gets the vaccine, what are your thoughts on this? I can't wait till we get there. Was it Dr. Agus's? I don't know, George. I don't know the answer to that. My goodness. Sloan recommended our channel. Thank you for that, Sloan. We appreciate it. How about that, Susan?
She's a crack up.
Yeah.
I want to get her on my show.
Yeah. Okay. So people are coming at. I've seen this a couple times on the thread also. That they're coming after Dr. Fauci for saying that we shouldn't be encouraged by a low death rate. I think he misspoke on that. I think what he was saying was, don't ride on your laurels that there will be an increase in the death rate coming. That's really all he's saying. It's that don't be reassured that the low death rate will continue, because in all probability it will not. And that's true. And by the way, today the death rate started spiking up a little bit. So, that's just true. I am very concerned about how bad things might get. They might get very bad, but we might choose to go through that. We have to really think about that as a country. Sweden chose to do that. I'm sort of feeling like people are getting to the point where they might opt for this. They're so despairing. They're so sick of the isolation that they might be willing to take a risk. And I personally am willing to take a risk, and I'm getting near a risk category. So it'd be interesting to hear what do you all think on the chat? Do you want to take a risk? You willing to take a risk? Do you wish that we just proceed with caution and use distancing sort of maneuvers, and that's it? No, Ashley, I'm worried. Ashley, yeah, a lot of people are willing. I'm worried that if we all took that risk and we all marched into it, it could get nasty. It would get nasty, and we might think otherwise of that decision at some point down the line. And the point we have to understand, and that Dr. Fauci doesn't think the risk we should take, is that once we get there, there ain't no turning back. It really, the genie is out of the bottle at that point. And so it's a, and it might not be that bad because hydroxychloroquine is working and remdesivir is working. There's lots of things working. Dexamethasone is shown to be useful. Steroids are helpful. Younger people are having an easier time of it generally. So these are hard decisions. Sweden was worse off than surrounding countries. Yes, they were. Of course they were. Of course, Matt, they were. They took it. They are exactly what I'm talking about. It got bad. And that's what would happen here if we just let it fly. It will get bad. But the question is that worth it? How bad? How will we feel about it when it gets scary? Personally, a lot of you are saying you're ready. You're ready to courageously walk forward and do this. I feel the same way, but I'm certainly not saying that's what we ought to do or what you should do. I'm just raising the question for something we should be thinking about as some big decisions come up down the roads here soon. Okay, we can do both, George. How do we do both? You mean you let it out of the bottle and then you lock down? That doesn't necessarily work very well. That's kind of what happened in Wuhan.
Somebody says, describe scary.
It's an unknown. I mean, something where let's say the hospitals are overloaded, and let's say millions and millions of people are sick simultaneously, and hundreds of thousands are dying. Could happen. Could happen. Is that worth the risk? You guys have to really think about that. And people being stuck at home and sort of being cared for as outpatients that, be better served in a hospital, but we just don't have the hospital beds. I mean, this could happen. It's possible. And if you're going to make a very aggressive move, you have to be prepared for the potential. It might go just fine. It might be hydroxychloroquine works beautifully and everyone, or that we have some monoclonal antibodies available. So it is a challenging question. Or you lock down again.
That I don't want.
Well, a lot of people don't want that. A lot of people are really, and the question is, do you trust the government just to hold it at 2 weeks? Will they just lock for 2 weeks, or will they lock for 2 months? And if it's 2 weeks and it continues escalating, will they hold you another 2 weeks and another 2 weeks? I mean, it's really rough. So, yeah. I'm taking quercetin and zinc, Mallory. I'm doing it. Zinc, D3C, melatonin. Yeah, that's me. Mallory, I'm doing all that stuff too. But that I'm not recommending it. I'm saying that's what I'm doing. And you can watch the interview with Dr. Zelenko if you're interested in that, where we talk about the hydroxychloroquine, zinc, and quercetin story. I think you'll be intrigued to find that out. No shots of Lysol. No.
I took this shot of Periscope. I thought it was really cute.
Aaron, you're talking about the airborne virology, and the reality is, though, very little. It's clear that transmission is proximity times time. That determines transmission. So worrying about it at a distance is very unusual for that to happen. Now, you could argue that if we really get a lot of people sick, that there could be sort of a viral load in the environment. It's possible. That's possible. These are the kinds of things that have to be taken into consideration when you take aggressive measures one way or the other. Or is there an intermediate zone that we should be following? Some sort of, and I'm telling you the intermediate step is wear your damn masks, social distancing, etc. Actually, zinc can affect copper metabolism, so you have to be careful. Don't take it indefinitely. Talk to your doctor about it. And it's nauseating at 50 milligrams. So
I don't take any of that stuff.
I gave you the quercetin.
I took that.
With zinc. You have to.
I didn't get zinc, though. I don't have any.
I am going to order zinc right now for you.
I have some in New York that you gave me when I got sick.
Right. So I'm going to order you some
At
zinc.
Christmas, I got sick and you gave me zinc.
Well, that's good. I was on my game all the way back then.
I know. Before you knew. Oh.
Yeah, well, I kind of knew zinc was going to be a part of the story. I could kind of tell what was shaping up.
But I don't think we thought it was COVID-19. I don't think
we didn't know. We didn't know. We really didn't know about it back then. C,
but I remember
C also, Susan.
We
right?
texted Johnny and said, "Thanks for giving us SARS."
Yeah, we did say SARS. That's true. Do you have vitamin D?
Yes.
You take vitamin D. Do you take vitamin C?
Yes.
Oh, you do.
Occasionally.
Oh, you're going to get.
And
that
I also
also
drink. I also have a lot of lemons every day. We have a lemon tree.
You counter that with vodka, though. So it sort of takes out some of the benefit. Here's zinc. Zinc coming your way. Zinc and vitamin C.
It's like one more pill. I can barely swallow all of those.
You should see what I have to do every morning. It takes me 10 minutes to get my pills together. Because I'm hypertensive, hypercholesterolemic, insulin resistance, prostate cancer, all those good things. Okay. Anthony, what was the truth? I'm sorry. The truth comes out about what?
About my vodka.
Oh, maybe that's what he's talking about.
I'm a chick.
Okay. Okay, I don't see much else on the thread here. How much zinc? 50 milligrams per person.
Monica said, I'm drinking grapefruit vodka and diet cream soda tonight because I heard it keeps the Rona away. That sounds really yummy, actually.
Don't give her any ideas.
I can't get Fresca anymore. It's the weirdest thing.
Travis, I am not recommending quercetin. Dr. Zelenko recommended it. It comes in 500 milligrams. He recommends it. I'm taking it. I don't have enough science to make strong recommendations about this stuff yet. That's Dr. Zelenko there in that picture.
He was awesome.
Yes, low vitamin D levels do seem to be a phenomenon in all of this. But exactly the degree to which it's involved, I don't know. Oh my God, you guys are your alcohol. The whole thread is now dedicated to alcohol. Let me say clearly, alcoholism is up in the diseases of despair we're amongst. So
I think my liver's going to go before I die of COVID. Be
careful. Olivia, you're talking about Disney and Disney World. I've seen the precautions they're taking. They're essentially going to run like restaurants. It's going to be it's still not it's risk to go out. It has some risk, but they're doing the social distancing thing. It's very good. All right, you guys, thank you for being here today. We appreciate it. Tomorrow we have Rob Henderson in here. Susan, you ready to wrap it up?
Yeah, I was just going to set up the banner. Don't forget to mention that you're going to be on
Fox 11 in about 2 hours here locally in Los Angeles. Do you mean that?
Yes.
Okay.
I'm going to show the banner so that everybody can see.
Mm-hmm. Alex and I. And I'm going to get my hair cut like that again tomorrow. I'm dying to get rid of all this quarantine hair.
Or ball on your head.
Yeah. So, okay. Thank you guys. We'll see you tomorrow.